evaluation. If that child is 12 to 18 months, sort of that peak age at onset of, peak age of manifestation of autism, and they've lost some skills, it's harder to predict whether or not that could be related to neuroinflammation. I think it's still worth looking, but not perseverating on that. That's sort of the onset of symptoms that look like autism, and they can look very much like autism. More commonly, what we actually see is the child with autism who develops PANSPANDAs. And somebody just says, oh, it's the new school. And actually, when I talk to the ACAP folks, I show 2 vignettes, which actually we experienced in our clinic. One was a boy who had a very abrupt onset of OCD. He was nonverbal, so you couldn't really tell what was going on, but he had been previously able to get to school, work with his aide, everything was fine, and it just all fell apart very quickly. He also had started having more daytime accidents of urine, and the sleep pattern had changed. So in that one, we depended on sort of those somatic symptoms. That one we worked up and felt he met criteria for PANSPANDAs. The second child, the history was that he had had a really rough school year. He had been previously with a one-on-one aide, and they thought that he was ready to be moved more towards mainstream, so he was in a classroom where there were 4 children to each aide. And he didn't like that lack of attention, and it had been rough all along, but things were progressing until Christmas vacation. They had a great Christmas vacation. He went back to school, and all hell broke loose. And the family was quite convinced it was PANSPANDAs. Absolutely no comorbid symptoms, no other changes in the somatic symptomatology, no history of exposure to strep, Lyme, mycoplasma, or anything else. And when we just, with the parents' begrudging agreement, we said, let's just watch and see how things go and how things progress. He did not progress in the way a PANSPANDA's child had been. So I think you should consider the diagnosis, but it's no more common than in neurotypical children, probably not any more rare either, so it does happen. Yes, sir?
So your description of the onset or of the symptomatology seems to be very abrupt and extraordinarily severe. Is there no indolent course? Is there no more subtle course?
There's no indolent course, but there definitely are subclinical and mild clinical cases. And those, we actually describe a vignette in the treatment guidelines because we want treatment to be graduated in proportion to what the symptoms are. So we recommend use of non-steroidal anti-inflammatories for the child who is exhibiting new separation anxiety, urinary symptoms, maybe some sleep symptoms, maybe some OCD, and it meets criteria because it's an hour a day, but they're getting to school, they're able to do their homework, still able to interact with peers, and they're a relatively happy person. That's a mild case and can be dealt with often just with administration of antibiotics, sometimes non-steroidals. Mild to moderate range is the child who the parent has to take them to school now, whereas they used to just be able to stick them on the bus, but they're afraid if they get on the bus they might have to have a bowel movement, and therefore they're not going to stay on that bus for the 10 minutes it takes them to get to the school. Parent drops them off, difficulty letting them go, and in fact the parent has to promise to sit in the principal's office for the first hour. She gets the call from the classroom that the kid's doing okay, she can go back home. That's mild to moderate. In that child, you're going to use steroids, obviously using antibiotics. Begin looking for your cognitive behavior therapist because that child's likely to have continuing OCD symptoms. By the time we get to the moderate range, things are not going well at home. This syndrome, like Alzheimer's and everything else, the kids get worse at nighttime. And we knew that from OCD in general, right? The kids would hold it together during the daytime, and then they had to do their rituals at home. And it caused all kinds of problems with family dynamics. But in these kids, it's actually a sundowning effect, where the longer the day goes on, the worse the symptoms are. And because the insomnia is so terrible, the evenings are just hell in that house. Those children, I think, if IVIG is available, I would try it. If it isn't, IV steroids or high-dose oral steroids would be appropriate. And then we recommend that we recognize plasmapheresis is available very few places across the country, so I recognize that this is a ridiculous recommendation, and we'll work with you to the best we can to substitute something else for it. plasmapheresis for the children with severe life-threatening symptoms. These are the kids that cannot even take in fluids, and so you are talking about having to put down an NG tube or IV hydration. The child's already been in the emergency room 3 times with IV hydration. You check the weight, and this formerly 75-pound child is now down to 60. That's a huge percentage body weight loss. And so those kids, very aggressive treatment. Antibiotics, IV pulse steroids plus IVIG, and as quickly as possible plasmapheresis. They hopefully will respond, and then you're just doing symptom control in the intervening times. And I purposely, you're right, I told you about our worst case scenarios, because that's kind of what we see. If you're a quaternary care center that works for the federal government, you're just going to see the worst of the worst. But you guys have probably all had one in your practice that was mild enough that you just gave some reassurance, checked those cultures, treated when positive, and the kid was better in 2 to 3 weeks. I'm hoping that's the usual case. Yes, sir?
So then what's the natural course of the disease if it's not treated?
I don't know. My best guess is that it goes along with the Martha Denkla, outgrow it, overgrow it, grow around it. So I've seen all kinds of adults. I've seen the adults who had an early childhood history of fairly significant OCD, a relapsing or remitting course that went on for 2 or 3 years, and then it was just gone. And they were completely asymptomatic as adults. The young men that I talked to you about, my first assignment at the NIH was to actually go over to St. Elizabeth's Hospital, sit in the dark for 3 months and trace caudate nucleuses on planometric CAT scans. And that's how we found that the volume was decreased. In that particular group of young men, they had early childhood onset and early relapsing remitting course that had become chronic and quite treatment refractory. Despite the best drugs and lots of behavior therapy, they still were pretty symptomatic. That would be worst case scenario, and frankly, most of the kids are probably in between. Let me tell you what the treated history is in contrast. I told you we had just published the 3-year follow-up on the kids from our IVIG trial. They were doing quite well as a group. Even more remarkable was the long-term 8 to 10-year follow-up on that first group of kids who came in for the treatment with plasmapheresis or IVIG. They were over 3/4 of them, nearly 80%, had no obsessive compulsive symptomatology. They were not on drugs, and they weren't continuing to use behavior therapy. Now, granted, that was 8 to 10 years, and we had 2 to 3 years as sort of a rocky course, but it can be completely eradicated with good aggressive prophylaxis and nice management of the symptoms while they're present.
How did the control groups do from those 2 studies then?
So we didn't leave anybody untreated, so we can't answer that natural history. The only thing we could do was go back to our large cohort, the 125 children that were followed in the drug trial, and look at the course of the kids who had pandas that we didn't know pandas existed. And those children looked just like the rest of the OCD children. They were still requiring medication, still fairly symptomatic, and all of them met criteria for OCD. They had at least an hour a day of symptoms. And the remission rate was less than 10% in that group. So we think it does make a difference. All right. Well, you guys were very patient. I really appreciate you coming out tonight, but you better go so you can come back early in the morning.